about problems as far as growth hormone is concerned. We went through congenital, so now we're going to look at acquired hyposomatotropism, which is also called adult onset growth hormone responsive dermatosis. So what do you think the lesions are going to mainly be? Skin problems and stuff. And basically it's a problem with an abnormality of the hair cycle. It primarily affects your Nordic breeds and toy or miniature poodles, but you know, toy and miniature poodles fit everything, right? So far. So other names for the condition, there's a good many of them. You'll see adult onset growth hormone deficiency, as we said, growth hormone responsive alopecia, castration responsive alopecia, hair cycle arrest, and more recently they've started calling it alopecia X. And alopecia X is very characterized. We'll learn about that a little bit later because it's under the adrenal problem because it's associated with inhibition of, not inhibition, but excessive secretion of your sex hormones by the articularis of the adrenal medulla. Also, that's called adrenal hyperplastic-like syndrome. Okay. Now, as far as etiology is concerned, it can develop in the adult following destruction of the pituitary gland by any problems, inflammation, neoplasia, trauma, etc. And this is the most common thing, and depending on how extensive this is, you're not, is trauma just going to say, I'm not going to affect that part of the pituitary, I'm just going to hit this part. So you can get pan-hyperpituitarism with it because it can destroy other areas other than the somatotropes that are up there. And the same way with neoplasia. Now, excessive amounts of cortisol and sex hormones, for example, progesterone, estradiol, and testosterone, that come from the adrenal gland, in other words, down there in the reticularis, will suppress growth hormone secretion. And then growth hormone will also suppress serum secretion, so they work hand in hand like that. And it can be associated with adrenal hyperplasia and tumors, in other words. In other words, it started out down there, but it's inhibiting growth hormones, so you get hyposomatotropism. You still have those excessive sex hormones going on also. Okay. The incidence, more common than the congenital form, of course, and it may develop in the adult dog, less commonly in the cat. There seems to be a little increased incidence of it in the cat, but it's still much more common in the dog, and it's still not very common. All right, signalment, age of onset is 9 months to 11 years. That's a really narrow range there, isn't it? Mm-hmm. But most of the time, about half of them will occur prior to 2 years of age. Okay? It affects dogs of both sexes, regardless of neuter status. It can occur in any dog, but it seems to have a predilection for the Chow, Pomeranian, toy, miniature poodle, Keys Hound, American Water Spaniel, Alaskan Malamute, Siberian Husky. These are all those Nordic breeds. Norwegian Elk Hound and the Samoyed. And if you notice, when we have these case demonstrations, usually we'll have one of these breeds that more commonly have these diseases in their animal. Okay. Seasonal growth hormone deficiency will occur in Airedales, Boxers, and English Bulldogs. So it's not really any problem with, it's not hyposomatotropism, it's just a breed predilection that they do this. And that may have something to do with what the bulldog looks like, right? Okay, so clinical signs, again, it primarily affects hair growth and skin pigmentation. What you'll get is a gradually progressive, doesn't itch, it's non-paretic type, there's no inflammation involved with it. Bilateral symmetrical alopecia, the trunk, the neck, the ears, the tail, cotyledonal thighs. Often you get sparing of the head, and you get sparing of the legs, particularly the front legs, for a while. Okay. And basically, when you lose the hair, what's going to happen to skin pigmentation?
Hyperpigmentation.
You get hyperpigmentation. And alopecia X, you can have a dog that's a brown dog, but it's the color of that chair right there. It's got all the acanthosis nigrans associated with it. Okay. In chronic cases, the skin becomes thin and hypertonic. Is that going to make it more predisposed to bacterial infections and that type of thing? So as it persists, you can get infections not because of the hormone, but because of the effects of the lack of hormone upon the integrity of the skin. Okay. Otherwise, other than the skin, the animals are basically normal. Now the cat can show a few more symptoms. They can get very aggressive at times, or they can get very lackadaisical at times. The cat, will do anything.
I'm sorry, what did you say about the skin being hypotonic?
It's going to be hypertonic. It's going to be hyperpigmented.
Okay.
And hypotonic. What's hypotonic mean?
Well, that's what I was wondering. It's on your slide. It's hypotonic.
Yeah,
So-
my voice is bothering me today, so it may sound like hypo.
Okay.
And what does hypotonic mean? What does it do to the tension of the skin and all that kind of stuff? You get very lax and everything.
Are we saying the right word here?
Now, it's hypotonic.
Okay.
Yes, okay. And this is just an example. Sorry, it doesn't have any color, but I can find one. But you can see is that's definitely not a normal hair coat. That little dog at the top, and you can see it's losing in areas. It's also getting some excessive pigmentation in areas. And you can see that poodle, that is not a trim job, okay? It wasn't taken to the groomer to get that. And also you can see the hyperpigmentation you're getting there. If a groomer does that, then you need to find a new groomer, right? Here's another example, and you can see the thin hair, those areas, still has a lot on the head, starting to lose it on the back and the sides and stuff. But see how you're getting increased pigmentation of those areas. Now, as far as clinical pathology is concerned, it's basically normal. You're not going to see much in the CBC, chemistry, or the urinalysis. And this is one way we use the differential diagnosis. Because of a lot of the diseases we talked about, give you the alopecia and all that stuff. And so the hypothyroidism can do it. Adrenal problems can do it, all these types of endocrine disorders, but they will cause some remarkable changes as far as clinical path results are concerned. So the lack of having anything can help confirm this diagnosis. Okay, now as far as the diagnostic procedures, again, you can get a tentative diagnosis based upon the signalment, the history, the physical findings, the lack of clinical pathological alterations, and also you can do a skin biopsy, and you'll see specific things in there. You'll get hyperkeratinoptosis of some areas. You'll get what we call flame follicles, where the hair follicles get real thick and everything. And what's that going to do to the hair that's in there? If you increase the distance between the nutrient supply and the hair, what happens to the hair?
Falls out.
It dies and it falls out. So you're going to see that type of thing. Now, basically, again, you have to rule out other causes. Okay? Now, if all the information supports that you have a growth hormone responsive dermatosis, what you can do is to try and see if a growth hormone stimulation test works. In other words, you give the animal, growth hormones, xylazine, this type of thing, to give it that's going to normally cause the growth hormone to go up. And you give it to the animal and it doesn't go up, does that probably tell you got a problem with it? Or you can basically do growth hormone therapy, replacement therapy, and the animal responds, and that probably tells you that. Sometimes we have the results of that type of diagnosis is to, you can't figure it out one way or the other, then supplement the hormone and see if you get a good response. If you get a good response that corrects one of the problems, then that's your diagnosis. Okay. Treatment, and it's going to depend upon what's the cause of it. If it's due to a primary loss of pituitary somatotropes or inhibition of their secretory function, then what are you going to have to give the animal? Growth hormone supplementation. And the synthetic human growth hormone is the best, but again, when it's got human in there, the cost can be exorbitant on that. There have been cases where that stuff treatment can cost up to $120 a day. And if you got to do it at three times a week, or it's 4 to 5 weeks, what do you think? You know, my dog would probably worth that, but I still wouldn't pay it. Okay? All right. Bovine or porcine growth hormone works, and you can use that. It's administered at a dose of about 0.1 international units per kilogram, sub-Q, 3 times per week for 4 to 6 weeks to correct the alopecia. Now, you can correct the alopecia, it looks good, so you can go off of the therapy, but is it going to go away forever, or will it probably reoccur? It's probably going to reoccur, so you have to be ready to do it again. There are some adverse reactions to growth hormone. You can get hypersensitivity reactions. You can get carbohydrate intolerance. And can you live a long life with any one of those problems? So what are you going to have to do to your growth hormone therapy? Stop it. Because what's worse, those two things or just the dermatitis?
Those two.
Those two. Now, if the condition is due to excessive sex hormone secretion because of the adrenal tumor and the reticularis and alopecia X, this type of thing, what do you think is going to be the treatment for that?
For tumor?
Remove that tumor. Okay. Now, what has probably happened to the somatotropes as that's been inhibiting their secretion? Are they going to bounce back right away? So you're probably going to have to supplement with growth hormone and gradually decrease the dosage and see if those things come back. If those somatotropes do not recover, then you will have to treat the animal periodically with growth hormone because it's not going to come back. Now, one of the things, if it is a space-occupying tumor of the pituitary, what's the best treatment for that? Surgical removal is the best, but can we often do that? But if we can, then the best way to do that is to take it out. The problem is, because you also be causing, you take that out, and that tumor has been compressing the other cells up there. So can you maybe have to supplement with thyroid and everything else for a while? You have to do that. Now, regrowth of hair is used to assess the response to therapy, of course, and that's going to occur usually within 4 to 6 weeks of initiating treatment. So don't think you're going to get it immediately. It's going to take a little while. But within 4 to 6 weeks, it should come back. Hair should come back. Now, your prognosis, of course, is going to depend upon the underlying cause. If it is a space-occupying tumor up there that's crowding out those cells, prognosis is going to be guarded to poor. On the other hand, if it's a if you can successfully correct it, such as taking out the adrenal gland, that type of thing, then prognosis is usually good. Okay, this is just showing you some examples of hypersomatotrophism, which is the opposite of what we were talking about, right? And what's wrong with that cat's head?
That jaw though.
That jaw, the
Yeah.
bottom jaw is coming out, isn't it?
Yeah.
Ornathia inferior, right? Now, there's question marks under that bulldog over there. Does that look normal proportions?
In the cat, no.
So could it be an underlying endocrine disorder that maybe has caused that breed to look like that? They thought somebody liked it, so they kept breeding them, and so they kept propagating that? They never proved that, but it could be a possibility, couldn't it? How many of you know have seen American Bulldogs? Now, we have an American Bulldog who looks like that, but she weighs about 150 pounds. She's a big dog. Now, my husband overfeeds her with treats and all those type of things. He's cut back on that a little bit. She's getting overweight like crazy. Okay? Right, so as far as hypersomatotropism, it's basically, as we say, overproduction or excess administration. In other words, hydrogenically it can be caused. But as far as in the animal, if it's an overproduction of growth hormone, what you're going to see depends upon what age that animal is when that occurs. Okay? Gigantism, what does that mean?
Big.
Big, right? Big proportions and everything. If your hypersomatotropism occurs before you have epiphyseal bone closure, the bones can still grow. So you're going to get increased length of the bones, this type of thing. So that gives you gigantism. Now, if it is after the animal's epiphyseal junctions have closed, can the bone increase in length? Can it increase in width?
Yes.
And that's why you get acromegaly. And acromegaly is a thickening of your membranous and long bones of the body. Okay, as far as the causes of hypersomatotropism, it could be a spontaneous growth hormone production by a functional adenoma up there. And this is in the parasistyles. And this is the most common cause in cats and humans. It can also be stimulation of growth hormone secretion by progesterones. For example, progestrogens, medroxyprogesterone, acetate. That's more common in dogs than cats. Why do you think that is? What do we use that for? Okay? You've got this client that has this purebred female whatever, and she comes in and she says, the fence got knocked down by these dastardly brutes and they came in and assaulted my little girl here. So you can use it for mismating. Okay? And it can cause some problems if you're not careful with it. All right? Now, you can also have excessive gonadotropic hormone releasing hormone. In other words, your growth hormone is inversely proportional to the sex steroids as far as levels are concerned. So if you have an animal that is producing a bunch of growth hormone releasing hormone rather up there, what are your sex hormones going to be? They're going to be low. What's the growth hormone going to be? It's going to be high. Now, you hope that as that goes, it may not see it right away, because you hope with that increased growth hormone levels, it will start to decrease your sex hormone levels, and so you can pick up signs and things associated with that. But sometimes it doesn't happen until after this has occurred. Also, what's the inhibitory substance that produced by the hypothalamus? Somatostatin. What if you have decreased somatostatin production? What are those cells down there in the pituitary going to say? Oh, we can have a good time here. We can party and everything and start producing a bunch of hormone. Okay, so those can happen. And basically, this has been more often reported in dogs. They did see it in a very clear example. The first case was in a dog that had a hypothalamic astrocytoma up there, and it was producing these effects. Okay. Ectopic growth hormone production has been seen, it's been documented in humans, and it's been documented in a few animals, but they don't have enough to say that this is a big problem. But ectopic production of growth hormone can be made, lots of your lung adenocarcinomas can produce various hormones, and it has been associated with growth hormone production. Also, pancreatic islet cell tumors in humans have been associated with producing things other than what they're supposed to produce. And growth hormone is one of the things that they've been found to produce. Okay, excessive exogenous growth hormone administration. Why on earth would we ever do that? Why would we give animals excessive growth hormone?
So they grow faster.
So they grow faster because, you know, that money thing, you know, you get a bigger animal, what's the market value do? Increase. And one of the problems with that is, particularly in beef and things like that, and what's some of the major things we give dogs and stuff to eat?
The viscera
Those
from.
things, and they may have residual levels of that. People also can eat the meat that's been, from the animals that have been given these things, and there have been documentations that it has caused increased problems as far as the consumers of this is concerned. Okay, there's a big argument on that, so I don't know if we'll ever solve it. Anytime you talk about economics, it's going to go on for a long time before they make up their mind what they're going to do, right? Okay. So here is a section that's come from the pituitary gland, and it is stained with aldehyde fusion, which stains for growth hormone. And the cells which are staining orange are somatotropes. And you can see, now somatotropes are about 50% of the cell constituency of the pituitary, right? Does that look like a little bit more than 50% there? That's closer to maybe to 80% or 90%. So this was a tumor, of the somatotropic tumor up there. And it was producing, it was a functional tumor, so it was producing excessive growth hormone. As far as gigantism, it occasionally occurs in all species of domestic animals. Acromegaly occurs more often than gigantism, but it is still relatively uncommon. And as I say, the English bulldog, I mean, look at that. Is that normal proportions there? So just need to think about that. You know, I like bulldogs, but I mean, they're strange with them, aren't they? Especially when they slobber on you. All right. As far as the signalment, doesn't appear to be any apparent breed or age predilection exists for canine hypersomatotropism. Most cases, though, have been seen in intact older female dogs. Now, the sparse number of reported cases of neoplasia-induced acromegaly, how do you determine the incidence rate and all that stuff? You got to have enough N number, right?
Mm-hmm.
And to determine what sex, what breed, and all that thing, you have to have N numbers, and we don't have enough of those to statistically say, yes, this occurred more often in this type of dog or this type of cat and this type of thing. So, but most of the cases have been in males about 8 to 14 years of age. Okay, that we've reported. That doesn't mean that's the most common, but what do we base incidence rate on? The number of times we see it, right? If we don't see it, we can't determine its incidence. I know statistics is an evil word, but we have to do that, right? As far as the clinical signs, you know, remember that growth hormone has both catabolic and anabolic effects, right?
Mm-hmm.
So if you have too much of it, what's going to happen to those effects? You're going to exacerbate those effects. As far as the anabolic is concerned, they're mainly, remember, the main anabolic effect is to get the insulin-like growth factors produced. And so that's those somatometins we call. And so basically that's what mainly the clinical signs come from, is having that insulin-like growth factors increased. And what you see as far as the respiratory system, you're going to have inspiratory stridor, like that, okay? You're going to have a transient apnea, panting, exercise intolerance, and fatigue. As far as dermatological signs, you get mixed edema. What's mixed edema? when you get that mucopolysaccharides accumulations in the submucosal tissues and stuff. You get excessive skin folds with the increased extracellular matrix. What's hypertrichosis? Increased hair growth. I mean, all these other things cause loss of hair growth, don't they? This can cause increased hair growth. Hyperkeratosis, thickening of the skin, dermal and epidermal hyperplasia. So you can see why we're getting all these, this mainly dermatological associated lesions as far as this is concerned. As far as skeletal or conformational, you'll get weight gain, increased body size, increased soft tissue in the oral pharyngeal areas, organomegaly, get big spleen, big heart, all that good stuff in there. A broad face and prominent jowls or jaws down here. You get pronathia inferior, so that the lower jaw protrudes beyond the upper jaw. And can that cause problems in the oral cavity? Because will the teeth line up normally, or will they be abnormally aligned? And that can cause abrasions and ulcerations and things like that. You also will get increased interdental space and rapid toenail growth, and also degenerative polyarthropathy. Okay, yes, sir.
And the dermatologic stuff, does it happen in certain areas, or is it like generalized?
It's mainly, it's more generalized than what we saw with our other problems with the other conditions. But most often it affects the head and the extremities the most commonly, but it can be anywhere. Okay, cardiovascular, you get hypertrophic cardiomyopathy, particularly if it's a cat. If you look at a cat funny, what can they get besides hepatic lipidosis? And you get cardiomegaly, right? And you can get a heart murmur because of this. All right, here's a couple of twins. Which one do you think has gigantism?
The left one.
The left one. Now, usually, when you have